Hello, everyone, and welcome. My name is Joe Caramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. Welcome to today's Grand Rounds presentation. During today's presentation, I'd like to encourage you to write in any comments or questions into the chat or into the Q&A, and I can go through those at the end with Dr. Henderson. I'll mention we have a core group of people that work on Grand Rounds each week, including Semhar Abraha on coordination and communications and Mike Walker on technology. We do record and then archive all the presentations, which are on, you can find them on the department website under Education and Grand Rounds. Funding for this academic year Grand Round series is through the Ripley Fund and the Garvey Institute for Brain Health Solutions. You're always welcome to write to me with any suggestions or comments on the Grand Round series. And close to the end of today's presentation, I'll put in a link in the chat for a 4 or 5 question brief evaluation. That's helpful for me in planning Grand Round. And with that, I'll stop for now and turn it over to Dr. Pamela Collins to introduce today's speaker.
Hi, everyone. I'm really delighted to welcome Dr. David Henderson, who is currently the psychiatrist in chief at Boston Medical Center and professor and chair of psychiatry at Boston University Chebanian and Avedisian School of Medicine, Dr. Henderson previously served as the director of the Chester M. Pierce Division of Global Psychiatry at Massachusetts General Hospital. There, he was also the director of the MGH Schizophrenia Clinical and Research Program, and he was also the director of the Harvard Program in Refugee Trauma. He serves as a co-director for an NIMH-funded T32 with Boston University School of Medicine and MGH with their Global Mental Health Clinical Research Fellowship. He has worked internationally for the last 25 years, mostly in resource-limited settings and those settings that have been affected by mass violence, disasters, and complex emergencies. He's conducted research and training programs in a very, very broad range of places, from Bosnia, Cambodia, East Timor, Ethiopia, Haiti, Liberia, New Orleans, and New York City, Rwanda, Peru, and South Africa, Somaliland as well. His work has consisted of field studies, needs assessments, mental health capacity building programs, focusing on specialized and primary health professionals, as well as skills transfer program evaluation. In the US, he has conducted more than 30 randomized clinical trials focused on severely mentally ill populations. So with that, we welcome you, Dr. Henderson. It's great to see you, and over to you.
Great, thank you very much. And I really appreciate the kind introduction and really the invitation. So let me just share my slides, if I can do that. Let's see. Okay, can everyone see that?
Yes.
Yes, we can.
Okay, great. So again, thank you for the invitation, and I wish I were in Seattle with you, but I'll take the cold weather in Boston, I guess. So again, I'm Dave Henderson, and I'm going to just talk a little bit about kind of a concept that I actually learned from Dr. Collins, this kind of global local approach, and I think somehow we stumbled upon this approach, and I'll describe what we've been doing. You know, we've established, when I moved over to BU and Boston Medical Center, instead of establishing a global program, we established a global and local Center for Mental Health Disparities. And I think, you know, I woke up one morning at like 3 in the morning going, aha, I have it. We're going to call it Glocal. And I was like really excited that, oh, wow, we're going to, you know, a new concept. And then I fell back to sleep. got up, I happened to remember my thoughts, and then got to work, and and immediately Googled local, and there's organizations and whole pages on it, a whole bunch of stuff. So it wasn't original at all. So we stuck with global local. But really the goal is to understand the local etiology of the diverse Boston population, which is a global population, but also to build from research to implement sustainable, culturally relevant mental health interventions in global populations, both locally and globally. And we are to engage in our global partners to foster exchange of knowledge and ideas, especially in low and middle income countries, and use evidence-based practice to confront gaps in access to mental health care, both locally as well. And then we have a strong responsibility to train researchers and clinicians in culturally diverse populations to inform practice and create relevant research initiatives. And that's what our center does, focusing on capacity building, research, technical assistance, and sustainability and evaluation. So I'm going to talk mostly about Liberia during this talk, just to give you some background. I've been involved in various capacities in Liberia since 2009, but people know the history of Liberia, I'm sure. What's interesting was that prior to all of the violence from 1989 up until 2003, Liberia actually had a strong health infrastructure and was considered one of the countries in West Africa, one of the countries to have the strongest health institutions and so on. And then it was all decimated by the violence. And so when we got involved, the country was obviously at a stage of rebuilding. There was clearly an absence of basic infrastructure to meet the needs of the population, including basic stuff like clean water and sewage, electrical services, and adequate roads. 85% of the population were living in poverty, and Liberia is considered one of the poorest countries in the world. And half the population is under 18 years old, so it's a very young country as well. And at the time when we became involved in 2009, there was only one practicing psychiatrist in the country, who was a Liberian, and who had trained outside of Liberia, but had been there at parts of the war, and then once the violence ended, he was there full time, but really the only person doing psychiatry in the country. Now, I put this slide in because for me, it's just a reminder of, a reminder for me to be grounded and to consider all possibilities, like not to quickly judge people. And so this slide, as you can see, now you can see there's a bunch of rocks in the road, and there's a young boy over to the side, and I was at a meeting at a hotel up on a balcony, and we were watching a group of people. We were watching this young man, and basically the child took the rocks and put them out on the road, and I was astonished by the group that I was meeting with, that basically, like, everyone there just had something bad to say about the kid. And why isn't he in school? Blah blah blah. Just all bad things. Even going as far as coming up with some psychopathology for the kid. And I just sat silently and watched. And so basically he put the rocks out on the road, and the jogger comes by, no big deal. And then a motorcycle comes by, and then no big deal, but he looks at the kid going, "Hey, what are you doing?" And then I didn't capture the third picture, but it was an SUV came by, and the SUV stopped in the middle of the road because it didn't want to try to navigate around these rocks. And the kid came running out from behind the bushes and moved the rocks to the side of the road, and then walked over to the SUV, held out his hand, and got paid. And so so for me, like, like I thought like there's no way I could feed my family on 10 rocks a day, but this young man figured out how to do it. And so we could easily say that this was bad behavior, but it also it reminds me of this is survival, and that we really can't judge people's behavior until we really understand their circumstances. And this is, of course, and when, working in another country, for me, I just have to sit back and watch for quite some time. Now, so I'm going to talk about this process of from Lowell, Massachusetts, which is a town or north of Boston, about 30 miles north of Boston, that is common to have waves of immigrants and refugees. And so there's a large Asian population, large Latin American population, and large African population. And it specifically, and of course they come in waves as well. And so I'm going to talk about Lowell, and I'm going to talk about Liberia, and how we've been able to work with both. Now, so this global and local connection, it started with a partnership with the University of Liberia and the Liberian Ministry of Health. And the first thing we did was we had to conduct a rapid needs assessment of using key informants as we were writing the mental health policy. But there was no data on mental health in the country, and in particular, there was no information on children and adolescents. And so we started with this collaboration, and we were able to write the mental health policy. And the gentleman on the right, we can see, is Dr. Ben Harris, the lone psychiatrist in the country, and the gentleman in the middle of this picture is Dr. Emmett Dennis, who was the president of the University of Liberia at that time and former provost at Rutgers. And so we wrote the policy, but in the process, or prior to completing it, we had to conduct this needs assessment. And our colleagues interviewed, I think, 171 key informants. And there, we really started a process where to conduct research that we really needed to utilize the students in Liberia. And then for this study, we utilized social work students and medical students to conduct the study. But obviously, there were a lot of findings. And again, this is a key informant survey, but certainly the exposure to substance use and violence and sexual violence, and identified adultification, trauma was common, and poverty and inability to accept or seek help, and exposure to infectious diseases as well. So these were some of the common themes that we found. One specific quote is, on average, children are neglected by parents or caregivers, and as a result, they are self-reared street children. Street children get into activities that expose them to rape, child labor, trafficking, and other child right violations. So really a very difficult situation in Liberia for children and adolescents, and actually no programs whatsoever to address their needs. So other findings from that study, including concerns about basic needs, housing, food, clothing. They were disconnected to the community with the goals to reunite the families or provide foster care or orphanages, or loving caretakers. And so, as you can imagine, with the prolonged violence and so on, there were lots of children who were left without parents. And then they recommended to focus on the academic, vocational, and life skills what we've learned is that really because of the nearly 20 years of violence, the educational system was in really bad shape, and people literally lost out on years of education. So even when it came to going to the university, very few could actually pass the entry exam because of the gaps in their education. And then health, of course, the medical care and counseling, which was critical. And so we wrote the mental health policy, and then really established this center of excellence with the university there. And one of the projects was to complete a paper that a study by Dr. Harris, Benjamin Harris. He did a study looking at adolescents' substance use and sexual behavior, but he never published it. And so we first worked with him to get that paper published. And let's see, and that's Dr. Harris, the lone Liberian psychiatrist at that time. And so findings from that paper, 51% of the population had consumed alcohol. Average age for use was 16 plus or minus 3 years. Within the drinking population, 78% reported starting before the age of 18, and a third reported drinking at least once a week. And I put this picture of the club beer in there. So if you've ever been to Liberia, you have to try the club beer because it's really good. It's really fresh. But with all the violence that took place during that 20 years of war or conflict, the only institution that was not damaged during those years was the club beer factory. So as you can imagine, regardless of which side you're on, everybody needed their club beer. And so that was the only place that was not touched, which is pretty remarkable. Also, identified, percentage of individuals, were having sex for money, and the, men were having more likely to have sex than women, but they were actually having sex on at least a monthly basis, so fairly regularly for these young people as well. And but there were some things in this study that we were concerned about, and particularly was whether we were asking the right questions. And so at some point, we went on to do qualitative studies. When we did this when I was still at MGH, we utilized our residents, and they conducted 4 different qualitative studies. I'm not going to go into the details of these studies, but just a little highlights. But one was assessing mental health and psychosocial status in the post-conflict Liberia. One was assessing traditional medicine in Liberia, and in there, the traditional healers, I think there were over approximately 50 interviewed. They basically gave us their diagnostic code book, and the paper has been published on that. The other one was the role of substance use and high-risk behaviors in public school students in Monrovia. And again, these are qualitative studies. And then the hopes and dreams of youth in post-conflict Liberia. So with the substance use in Liberia, the qualitative approach did 9 focus groups conducted in 3 public schools in Monrovia. And again, these interviews were conducted by the group of medical students, which I think has always been extremely valuable from an education and skill transfer position. And there was a quote, last year I had a friend who used alcohol all the time, even in class. It was red and they called it Big Mama. They sat back and would drink the alcohol in class. It was a group of them. Now, this is an important quote because we realized that we actually had the wrong language when we were talking about particularly alcohol or substance use. We were saying alcohol, and for some, they only knew it as Big Mama, but we had no idea about that. And so the importance of doing this qualitative work really helped us revise our study, and we went back and reconducted the study with a slightly different focus as well. Another quote: some people smoke and drink liquor to forget their problems. They're frustrated, so they do it to keep from committing suicide. You know, so some serious issues there. And so when we redid the study, the findings were fairly similar, but actually somewhat different. And we were able to uncover other areas of concern, and particularly the use of marijuana and heroin and cocaine, and other substances. One second, I'm just looking. And so so these were drugs that weren't really identified before, and of course we used the local names to help us better evaluate the adolescents and young adults' use of these compounds. Another study looking at the study of resilience and in-depth interviews to assess adaptive factors in 75 youth aged 13 to 18. Individuals involved in schools showed more adaptive functioning and resilience. This was particularly true for boys in any school setting and at girls attending private school. Youth not attending school were more likely to have lost family members or become estranged from them, and many were also engaging in substance use. The findings suggest that youth that have lost a caregiver, many of which are not enrolled in school, have interrupted daily function and poor psychological health in the post-war period and a priority for the future intervention. And so, again, as we start to build out programs and mental health interventions, I think this data is super important for us. Now, I've given you some of the results of the qualitative studies, but I didn't tell you how we actually got the results. And as I said, that we had the medical students conduct the interviews. They were audio recorded, but the interviews were all conducted in Liberian English. And none of us back in Boston spoke Liberian English, but we were quite lucky to find a church in Boston, or north of Boston in Lowell, called Christ Jubilee, that had a Pan-African congregation with a large Liberian group there, and the pastor was actually from Liberia. And so we partnered with the local community and the church, the Christ Jubilee International Church, and they helped us transcribe the qualitative interviews. And so we got a number of volunteers, and then we trained them. We got them the equipment for transcription, and they, over the course of several months, transcribed all 4 studies for us. Now, during that process, however, started to realize we would meet with them monthly, kind of have a debriefing, and started to realize that what they were hearing on the audio tapes, they had actually experienced themselves. And so we thought that, okay, we needed to do something more here. And first, for the transcribers, we developed this support program during this process. But then we started talking to the leaders of the church about what else could be done. And so this really began a kind of a long-standing collaboration that it was quite different than why we originally approached the group. but it started with a request for help. And so they were asking, as we were doing the transcription, they were reaching out and asking for help, and wanted to participate in some type of a needs assessment around mental health, and as well as a educational and awareness program. And so, you know, we got a team together. We kind of designed an approach. We decided to use a community-based participatory research approach, which is now quite popular. You know, we you know, worked with the church leadership and advisory board, and we really began this process of working through not only getting our data, but also conducting a study there to get an understanding of what are the issues that the members of the church were having, but then also to develop interventions, including holding health fairs and doing screenings for, you know, depression, anxiety, diabetes, hypertension, you know, that sort of stuff. And so it really, you know, working closely with the community advisory board, we selected several individuals. We worked to do kind of a mixed method study. We designed the study with them. We got lots of feedback. And then the members of the advisory board conducted the study. And it was very useful, of course. It was the women, it was the mean age for women were 38, for men it was 45. Larger percentage from Liberia and Nigeria, and then many other African countries. You know, fairly high level of education. Back to 61% had bachelor's degree or higher, and a high rate, fairly high rate of employment status, but lower than what is excuse me, expected for this region, and considerably lower. And here's one quote that I think is really helpful. It says, there's something they say in my country, we speak broken. That means even though we are here in America, we are still the same Africans. Excuse me. We still have the same belief. We still handle mental health issues and emotional health issues the same way. We don't understand that there is a cure for mental illness. Most of the time we believe it's weakness. If you're crazy, you're supposed to be on the road. If you're not wearing your clothes backwards, then you're not crazy. You don't have a problem. So that's how we view it. As you can see, there's many pathways for emotional and physical distress, and as well as barriers. And so we were particularly interested in the cultural barriers and the structural barriers. You know, as we designed interventions, including health fairs and trainings, we were very cognizant of these barriers. And I think it, you know, one person said, you know, culture has a lot to do with it. Sometimes they only go when they're about to die. And so we know that, you know, one of the findings was that even though subjects in this study had access to healthcare, they were not utilizing it. I mean, you know, Boston is what it is, and healthcare is lots of hospitals. The city of Lowell also has a number of community hospitals and health centers, but they were not actually utilizing it, even though it was available. Now in Liberia, people weren't utilizing it, but it wasn't available. Different pathways. And we learned about, you know, the differences between men and women in the congregation, which I think again is very, very helpful. And my takeaway was that while both men and women were going to church, the women were utilizing the church more and getting more out of it. The men were not. And the men often turned to more maladaptive behaviors to deal with their stress and anxiety and so on. And not surprisingly, the men underreported depression and anxiety symptoms when we did the quantitative component of the study. But when we did the qualitative component, when they would, and we asked questions, open-ended questions, and they were just talking, and we went back and recoded for the same depression and anxiety symptoms, the men actually, in the qualitative component, reported much higher rates of problems with anxiety and depression. So it's also for us an important thing to remember, that sometimes we're not capturing what we capture when we do these surveys and screenings and so on. And so we've been to Liberia, we've been in Lowell, and now I think we're gonna go back to Liberia. And one of the things that we proposed in 2009 in the to the Ministry of Health for the mental health policy, we proposed that the country needed to start training programs, and that we volunteered to help start the psychiatry training program, but also to make connections with other graduate level, like psychology and social work programs. Not everybody thought it was a good idea. There was a lot of resistance in the country, particularly from the school that trained social workers. And so, my hope was that in 2010, we would start a training program. Turns out we didn't. It took, let me see, it took another 9 years before we were able to start the program. And so we started the program in 2019. And the reason we were able to start it was for the government developed the Liberian College of Physicians and Surgeons, and they started, first wave of training programs were, I think, in like primary care, OB, and pediatrics and surgery. And we were slated for the kind of the second wave of new residency programs. And we had some practice, however, in that we had started a program, a psychiatry and neurology program in Hargeisa, Somaliland, back in 2014, 2015. And we did that with some donor money. And we were able to train 3 psychiatrists. We utilized our Ethiopian colleagues for some of the training. And then we graduated 3 Somali psychiatrists and neurologists in the country. And the problem was that we only graduated 3, and then the program was over. And that was simply because it was donor funded. Now, our advantage for waiting it out in Liberia was that once it got started, it was funded fully by the government. And so this really put us in a much better position to be able for sustainability. And this picture was taken in September of 2022. We went, a group from Boston joined our colleagues in Liberia as we graduated our first psychiatry resident, trained Liberian psychiatry resident. So now we actually have is Dr. Harris with the red handkerchief in his pocket, and to his right with the light blue blazer is Dr. Odejiran. He's a Nigerian psychiatrist that we were able to bring to Liberia. And then after 2 years of support from us, the Liberian government started paying his salary. And then we have The gentleman to the right, Dr. Moses, is our first graduate. And included in here are 6 or 7 other psychiatry residents. So in another 3 years, Liberia will have 10 new psychiatry residents that were trained in Liberia. And we really think that this is our greatest success. And so I'm really pleased about that. Now, in the last few minutes, I'm just shift gears a little bit, but it's all connected in a way, in that we have been working for several years now to establish the Africa Global Mental Health Institute in building global capacity through collaboration, brings together mental health professionals from around the world to accelerate capacity building for mental health care in Africa and the diaspora, facilitates intracontinental collaborations between more than 20 countries. I think we're at 25 countries that are participating now, and in sectors of mental health policy, training, education, research, and clinical services. And this is really important, but I want to tell you where this idea came from. And if you see this picture, and if you see who's in the front row, it's not only, of course, it's Dr. Pamela Collins, but back in 2002, Chester M. Pierce held a meeting in Boston called the First African Diaspora Mental Health Meeting. It's a fantastic meeting. A lot of Black psychiatrists from United States, but also from around the world came together. And so in many of, or in this picture, will show up in subsequent pictures as well. It was a fantastic meeting, and one of the issues or recommendations from the meeting was that that we establish an organization that allows for collaboration and for Black mental health professionals to come together to discuss the challenges they face in caring for and providing the care for their patients, and really to foster collaboration around training and education and research and so on. And so that was the recommendation. However, we were never able to do it, or it took us a long time to do it, I'll say. I think that it was the right idea, but I don't think that anyone was really equipped to start doing this type of work and collaboration to pull things together. And so, fast forward to this summer, actually September, we held our 5th meeting in Cape Town, excuse the typo. And again, about 20-something countries were represented. It's a fantastic meeting, and really people are starting to work together around sharing of resources, curriculums, writing grants together. It's really super exciting to see this. And the whole notion is that one could be receiving the assistance from someone who's already done something that you want to do, and also you could be helping someone else who is trying to do something that you've done. So it's you're being pulled up and you're pulling somebody up at the same time. And so if you're thinking of starting a residency program, you don't have to start from scratch. You come to us and we give you our curriculum that we use in Liberia and Hargeisa, and then you take that and adapt that to your country, your situation, your populations, and so on. If you have a training program and you don't have anything in substance use, you could go to our colleagues in Nigeria. If you want to do child and adolescent psychiatry, you can go to our colleagues in Durban. And so it's really to foster that type of collaboration. And really, the strength of it is the East-East collaboration, not the East-West collaboration. And that there's long been, questions about East-West and what are we doing, that sort of stuff. But it's really everybody helping each other and helping move their agenda forward. And so it's great that, you know, we've have the organization with revamping our website to make it as a resource for people. People will be sharing articles and curriculum and I've even offered to put all of my grants in there for people, whether they were successful or not, and probably most were not successful, but it could be of use to someone, you know, depending on their circumstances. And so, and others agreed to join in, and so it's really it's sharing of resources, and we think that it's going to be something that will be quite productive. And as I said, people are already writing papers together, doing webinars and seminars, and so on. And this is, you know, looks at what the website will offer, like member directory, grant proposals, funding opportunities, and so on. And this is it's just basically it's agmhi.org, and you can check out the website. All of the previous meetings, the recordings from all of the talks and discussions are on the website, so one can take a look at that and see what's of interest. In January, once the new website is up, we will announce a mentorship program, and this will be different in that, you know, it obviously be mentoring, connecting emerging researchers or scholars with more experienced scholars, and we'll pay the mentor a small stipend, and the mentee will be receive funds to travel to our next meeting, which will be in September in, I think, the Western Cape in South Africa. And so we'll be piloting that as well, and then we will also have a call for abstracts as well, with travel awards that'll go along with it. And this is just a list of some of the references. If you have an interest in some of the papers I've talked about, just shoot me an email, and I'm happy to provide them with you. And I think that's it. Yeah, we have some time for questions or discussion. And let me end the slideshow so we can see people.
Thank you, Dr. Henderson, for walking through this, and learning about the persistent effort, and then resulting in, I think, a 1000% increase in trained psychiatrists practicing in Liberia. I mean, from 1 to 10 soon in 3 years. Really, really notable and remarkable. I will ask others to write in questions, comments, and I'll go through those now. And Dr. Collins, I can turn it over to you.
Yeah, I have a first question. First, I also just want to echo thanks for this wonderful presentation. And as you saw on the slide, Dave and I have known each other for 20 years. We have been colleagues in this area, I think, both trying to figure out what are the best ways to get things done globally. And I really appreciate your emphasizing that we are a part of the globe, so that when we think about things locally, that's a part of this conversation about global work. So really appreciate this presentation. The other thing I particularly appreciated is that, you know, this is not easy work. And you talked about the difficulty of, you know, having a plan. It takes many years for that plan to be executed because there are many different forces, there are complex relationships that are involved. Just for people that are in this audience that may be thinking about, oh, wow, I want to do something. How do people really inform themselves of those, the policy context, the mental health context? But there are many things outside of the mental health context that you make clear that people need to understand. What are some of the best ways? You did that through some on the ground qualitative research, but what are the other ways that people can get an understanding of the complexities of the environment?
Yeah, I mean, I think there's lots of ways to do it, and I honestly, you know, when I moved from Mass General to BU and Boston Medical Center, I was like cursing myself because like I could have been learning these things right here at this hospital with my patient population. I could have done it right here. I didn't have to take all those trips. The trips helped, of course, you know, to be obviously in the country, in the environment, and for me, like I just gathered anything written, and I spoke to anyone I could who had any knowledge about anything, just trying to, you know, I guess, soak it up, but also try not to make mistakes, because like I made a lot in my early global days, like when I was working in Cambodia, and I assumed everybody was psychotic because if you ask them, do they hear voices, they think you're asking about their ancestors, and they say yes, and you know, like just like silly things like that. It's so easy. So for me, it's just reading and talking to people, you know, at all levels. You know, you can go like the global work. You know, oftentimes you're immediately exposed to expats, and they have opinions, and oftentimes they're negative. Their opinions are negative towards the locals, and so, but you know, but it's data nonetheless. There is the WHO has a website called MindGap, and that has a lot. They've tried to gather as many kind of policies from mental health policies from every country that they could find, and so you can actually find a lot of information there, and then maybe that connects to other areas as well. But again, I think it's just multiple sources. A lot of times there's not data published, and you can't go to PubMed and find an article, but you may find somebody's dissertation somewhere that was in the bowels of their library or something, you know, so you just have to just keep searching. So. And I do want to say, again, emphasize that my global local really comes from Dr. Collins, who opened my eyes to it, because, you know, I was just thinking global. So I really appreciate that. So.
Well, that's very kind of you. I'm not sure I completely believe it, but I think it's very kind.
It's true. It's true. And I remember where we had the discussion. It was at the APA. I remember exactly where we had the discussion. Yeah.
And about the global and local, I wanted to ask about the partnership with the Christ Jubilee International. And it's interesting to consider a partnership regarding data analysis. It's not a common partnership. I mean, more commonly, you might hear about information to inform questions, to inform use of measures, and inform recruitment strategies, and so on. But in the analysis is unusual. And it was interesting also to hear about the supports that you developed as a result of that. Did you go into that sort of specifically thinking about the data analysis, or was it a kind of broader, let's see if we can work together approach initially?
No, it actually started with the data analysis, the transcription. We knew we needed to identify people who spoke Liberian English. Now, there's a large Liberian population, and there's a church in Boston that I was about to reach out to, and then someone tipped me off that, hey, I just met this pastor in Lowell, and he's pastor of this African church, and he's Liberian, and I told him about the things you're doing in Liberia. He would love to talk to you. So they were attracted because of altruism, like they felt like they were helping their country. We were attracted because they spoke Liberian English, and so in the beginning it was contractual, like they were providing a service and so on, but it became clear that there was work to be done there, and that they were good people to work with, and it's strong leadership and eagerness. It's not every church that's eager to have you come talk about mental health to its members. But they, we were up there many Sundays, and they would literally give us half an hour doing the sermon, to break up the sermon and to let us talk about mental health and stuff. So they were very eager, and it just evolved into this mutual respect and collaboration. And COVID kind of disrupted it quite a bit. But we're about to start back with the next phase of the engagement, and here they want some of their members to be trained on brief trauma interventions, and and we have one of our colleagues does that. She trains lay people on brief trauma intervention, so it's a perfect match for that.
I thank you for the comment. It's an evolving relationship, initially with data analysis, and now perhaps an opportunity to train for clinical services within that setting. It's very interesting. Yeah, I think reflective of the persistence, longer term efforts, like in the example with the residency training as well. What was it like for the first resident? Did you hear? I mean, the first person doing any training program, there might be ups and downs. What's has it changed for the subsequent residents, or?
Yeah, because the program, we've had 2 attendings on the ground, and then in Boston we supplemented with online lectures every week, both for psychiatry and neurology. So as time went on, the curriculum got better, the lecturers got better, the internet connection got better, and so, but we knew that there were gaps, so we had to. We actually had 2 residents in this class who should have graduated. One has had some delays for medical reasons, and so will graduate soon. So then it'll be another one. But we had to, like, for instance, we had to send them to Nigeria for special training because it's just the services were not there. So now, particularly in substance use, so now they've come back and are starting a substance use program there. So we also they also went to to Durban and did some child, and so now we have a couple of docs in the country who are now comfortable treating children. But there was always bumps. It wasn't, there were many months where the government didn't pay them on time, and things like that. But I think things have all been smoothed out, and so we've I think it's working quite nicely. And now with COVID letting up, we're able to travel. So our residents from Boston will also go and train with them, and so that I think will be very special as well.
I appreciate that additional information and the opportunity for people training in different programs to learn from each other and from their clinical sites. That's very interesting.
Can I ask one quick question?
Sure.
We have a program here that where a chief resident, actually this is in internal medicine, a chief resident from medicine serves at a particular hospital in Kenya where UW has a longstanding relationship. And then both Kenyan residents and UW residents can, go there, train together. So Kenyan residents obviously are there, but UW residents also go. It's an interesting model that just was wondering, because it also allows the UW residents to be officially training, right? So they get credit for that as part of because they have a supervisor who's part of the system.
Wow, that's awesome. No, we don't have that, but I'll send you an email next week. let's do it. Let's do it together, maybe. But I mean, that would be an awesome thing.
Yeah, no, because we've been sort of struggling about, okay, if we want to send our residents, how do we also make sure that this is not just for fun, but it's incorporated into their residency training, right? Or into fellowship training, one or the other. I think that's what we've been trying to work out. This is for fellows or for residents, or how does one best do that?
Yeah, that's a great idea. I mean, we utilize our senior residents for didactics for the Liberian residents, but this would be a step further. That's a great idea.
I have to
connect you with our folks here. Okay, I know we have to stop.
No, please, it's nothing like a grand rounds that leads to an immediate next step. It's really, it's great. Global, local, and now this next step with residency training. Look at this. It's very good.
It's a great idea. Yeah.
Well, thank you, Dr. Henderson. We're just at 1 o'clock here, and we've had a great opportunity here to hear about this persistent evaluation using qualitative methods, including medical students in that process, establishing the training program, and more. And it's I appreciate it very much. This is a valuable presentation. We'll have it archived that people, starting to learn about global health and local and global health can also view to learn about and see, find some inspiration or ideas for next steps. So thank you again. I really appreciate it.
Thank you. Take care, everyone.
See you later. Bye-bye.